Okay.
Anyway, congratulations on your honorable mention in that magazine. I'm sorry you had to be the one to be the subject, but it was a nice article anyway.
I don't think that article was really about anyone or anything. It was too many topics.
Well, I had a good photo of you with your boys in the little toy truck. I thought that was pretty nice.
Yeah.
Okay. So we have a few people on the telephone here. I got to start writing, man. Jeez. Jake, you want to take care of the telephone whilst I write down names?
Yep. Anybody like to speak up so we can identify you?
Sure,
Jim
Alan
Harrington.
Moskowitz.
Okay,
Nope.
wait a minute. Jim Harrington, go ahead.
No, I just said my name, Jim Harrington.
Okay. I'm sorry. I gotta do them one at a time.
So Jim Harrington is number 5, I think.
Speak up again.
I think
Number two, I think. Yeah, I think so too, Peter.
Okay.
Okay, somebody else?
Yeah,
John Appler
Alan
just joined.
Okay.
John Allen?
John Appler.
Oh, speak up again, John.
Sure, John Appler, Jake.
Number
Okay.
5.
Got it.
And Alan Moskowitz was on number 2.
right?
Number 3, I
No.
believe.
Oh.
Yeah, speak up again, Alan.
Yep, Alan Moskowitz.
Yep.
I'm
got it.
here.
Number 3.
Okay, sorry about that.
I hope I don't destroy your last name. I'll try my best. Moskowitz.
Perfect.
All right. It helps
Well
having a Polish wife. I expect that's a Polish name, right?
No, it's not. Eastern European.
Is what?
Eastern European. Some people say Russian, but it was Russia or Poland way back.
Okay. Well, that's my wife's family's from Poland, so and
It's
some
close.
of them said they're from Russia, depending on when they came over, because they kind of switched places over the years. Anyway,
That's
welcome.
right. Thank
We have one other caller on the phone.
Dennis Correa.
Oh, hi, Dennis.
Hi. I'm also on the GoToMeeting.
You're just trying to fool us, I know.
Yeah, he's doing it. He's doing it again with the two connections.
Yeah, well, the microphone doesn't work on his computer. That's the problem. We know the problem. Father Santa Claus needs to bring you a new computer, Dennis.
Yeah.
You think so?
Okay, so I think I've got everybody's name written down. I'll do a roll call. Did someone else just join?
Bill Franklin.
Franklin. Okay. All right. So I'm going to call out all the names that I see. And then if I've missed anybody, please tell me. Peter Kafka, Jim Harrington, John Appler, Alan Moskowitz, Jake Hannum, Dennis Correa, Thibault Lincecum, Eric Bookbinder, Gabe, Paul Frieda, Gary Gumman, Gabe in twice, and Bill Franklin. Have I missed anybody? No.
Did you get Tebow?
I got Tebow.
Okay.
Cool, Tebow's name. Okay, the only name I don't recognize is Gabe. Hello, Gabe. Are you, is this the first time that you've joined us?
Rick, it's Jim. I think I'll introduce Gabe. He
you're
contacted me.
Gabe. Perfect. Okay.
Well, I don't know if it's perfect or not, but if he's on the phone, he would be welcome in the group, and he has a problem that we can help him with.
Yeah, no,
But he
Gabe.
contacted me.
Gabe is. I can see him. He's on GoToMeeting,
Oh,
and
okay.
see him. Hi, Gabe. Um, yeah, go ahead and introduce him because if he's not been with us before, we'll give him some priority.
Okay. Well, Gabe comes, he talked to me. He comes from us too, here in New Jersey.
Okay.
And he's got advanced cancer, and I talked to him today. I forwarded your email, and I said, I think you're going to derive a great deal of benefit from this group because where he is, castrate resistant and so forth, I think we can help him.
Okay.
And he just doesn't need to rely on me. So that's an introduction to Gabe.
Okay, so Gabe comes from the same group that you and Jim Cameron and I forget who else. Is that right?
That's right. That's right. The us2 group, very large group in Morristown, New Jersey. That's correct.
That's right. So what I should do before we talk to Gabe is I would like to just give you all a quick update on Jim Cameron. Since his name came up, I would have waited, but I'll do it right now. I guess Jim discovered early last week that he had what's called a fistula, which means that there is a hole between two conduits. In his case, one of the conduits was the colon and the other was likely the urethra. And this became apparent after they did a CT scan and they huddled and I think a week ago, Friday it was, his doctor recommended that he see a surgeon. So we all spoke, we all being myself, Jim, Pam, and Paul Korn at MD Anderson. And Paul, based on the information that he had, endorsed the idea that Jim should have colon surgery, which would result in him getting a stoma and an ostomy bag. And thought about it over the weekend and decided that that was what he wanted to do because the likelihood that if he didn't do it, he would get an infection, a very serious infection, was pretty high.
Ouch.
So he went in for surgery last. I'm trying to think. Today's Monday. I think he went in for the surgery. Oh, I remember what happened. He had some, I think, some unusual pain or some issues. I forget what. I just have to go back and look in the emails. And so they took him into the ER, and the surgery, which was scheduled for the middle of this week, was accelerated to last Friday. And they were able to create the stoma and give him an ostomy bag, but they also wanted to give him a suprapubic urethra, and they weren't able to do that because the tumors were interfering in some way or the other. I don't know more detail. So he was in a bunch of pain, and then this morning I heard from Pam that they had to take him into the cardiac intensive cardiac care because his heart was racing at around 250 beats, and so they had to do something, and that was the last I heard. So he's not doing real well.
Oh, geez. Sorry to hear that.
We're all sorry, I think, to learn about that. If any of you want to reach out to Pam or to reach out to Jim, just do let me know. I will give you his email address, or it's Pam's email address. She basically handles their email. And if you want to let him know that you're thinking about him, I mean, actually, I think I can probably do it here. Most everybody on the call knows him, so just bear with me 1 second, and I'll give you his email address.
Okay. In the meantime, we have a couple of other phone callers
Right. So hold
we'd
on.
like to identify.
Well, hold on. But we'll get to him. We'll get to him.
Oh, okay. I'm sorry. I thought you were looking something up.
No, it's right here. So his
Okay.
email, I'm putting it in the chat window. It's Jim Venice at Comcast.net. Comcast.net. So I'll repeat that. So that it's now in the chat window. And for those of you on the telephone, it's Jim Venice at Comcast.net. So we just have to keep him in our thoughts, and hopefully he'll pull through this. But the spindle cell, we knew the spindle cell was going to prove to be a very difficult customer, and it seems like it has been. So that's where we are. I'll keep you all posted. So, sorry to be the bearer of that news. Gabe, we
Yes, sir.
normally, since you are an old hand at support groups, we run this one much like most support groups, where if we have somebody new, we dedicate the first 20 minutes or so to them, and we invite you to tell us a little bit about your situation, if you're comfortable doing that, how old you are, your disease history, disease demographics, and how we can help you. Would that be comfortable for you?
Sure.
Please go ahead.
So I'm on the telephone and I can see your images. Now, I don't know if that is a problem as far as echoes are concerned, but I don't know how to,
Okay.
to work it.
So what you need to do is to mute your computer.
Got it.
If you can mute your computer, you'll lose the echo.
All right. It's not really gone, but
Or turn the volume down on your computer as low as you possibly can. That should do it too.
okay, good. So you could tell from my technical abilities, technological abilities, that I'm over 8 years old.
88, I would say. Not
Yeah,
8.
right. No, I'm actually, I'll be 76 in March.
Okay.
I was diagnosed when I was 55 years old.
Wow.
So I've been managing this thing for the last 22 years or so. And my original PSA was 26. I scheduled for a prostatectomy, and just before the prostatectomy, my PSA went down to 16. I don't know if that ever made a difference, but I had a prostatectomy, radical, and in those days, they cut and dice.
Right.
And so about 5 years later, my PSA started to rise again. It went up to about 6, and decided to have a radiation therapy. And that worked for another about 5 years. And then my PSA started to rise again to about 6. I don't think I've ever allowed it to go over 6. And then I started hormonal treatment intermittently. So it was never on a schedule. I would just, after the PSA went up to about 6, I would have another shot. So I've been doing that for the last about 12 years. and September a year ago, so that would be September of 16, I had a Lupron shot, nothing else, just Lupron and a bunch of supplements. And my PSA stayed down low until June of 2017, and then it went up to about 6. So I had another Lupron shot, and normally it would go down to 0, but it didn't.
Mm-hmm.
It went to 1.5.
Mm-hmm.
And then about 6 weeks ago, I had another Lupron shot, and it went to 1.75. So it appears that I am being refractored now.
Right.
And in addition to that, they discovered 20 months ago that I had a couple of bone meds in my spine. They said it was very small, tiny little holes. Don't know exactly what that meant, but they said that, well, just watch your PSA, and as long as your PSA is very low, we shouldn't do anything. However, now I'm concerned because my PSA didn't go down with the Lupron shot, and I'm looking for what to do next.
Okay. So I'm just so let me just see. In June, you said it went. In the June shot only took you down to 1.5, and then you were up to 1.75 by within how long?
No, after the second shot, I had another shot about 6 weeks ago.
So you got a shot in June that took you down to 1.5.
Right.
And then you were scheduled for another shot. It wasn't based on PSA. You were just scheduled for another shot about 3 months later, and you were at 1.75. Is that right?
Correct. So this is the first time with hormonal treatment that it hadn't gone down to 0.
Right. So in other words, you were kind of on like intermittent treatment. You'd take one shot. You wouldn't do anything else. You'd wait until it got back up to 6, and then you'd take another shot.
Right.
And who was managing your treatment, Gabe?
Really me. I have several different oncologists and urologists that I've been seeing. Dr. Stein, Dr. Katniss in New Jersey. I've seen a lot of different people over the years, but they're the two most recent. I always considered that if I managed the PSA, I'd be, okay.
Mm.
Now it doesn't appear that the Lupron is managing the PSA.
And who are you inclined to put in the quarterback chair?
Well, right now I don't know. Right now I don't know. I've always considered that, the more opinions that I would get, the better it would be for me. I always considered myself, frankly, I considered myself the quarterback.
Right. Okay.
Rick, I want to add that Gabe has not had any standing errors, I take it.
Right. No, clearly, and hasn't
Not yet.
and hasn't done any chemotherapy either.
That's right. And he's kind of been his own doctor, He's seen some in New York, some at Memorial Sloan, and so forth. So,
Right.
but sometimes being your own doctor is not the best idea.
Well,
now he needs help.
Who have you seen at Memorial Sloan Kettering?
Oh, years ago, let me see, Sloan. Geez, I forget, but it was.
You said Katz,
I recall
right?
a Dr. Katz. He went over to Winthrop. He was more of a holistic.
Okay.
But he was giving me, Lupron, but he was also promoting the holistic approach.
Right. And you said you've taken other supplements. What supplements have you taken?
Calcium, magnesium, vitamin D3, vitamin E, C, resveratrol,
Mm-hmm.
magnesium. I can hardly think of all of them.
Well, and
Pomegranate,
okay.
Um,
Do you just take these or do you measure your levels and take them based on the levels, or do you just get a bottle and just take them as you see fit?
no, I mean it's been I don't know how many of you know Doctor oh gosh uh, Snuffy Myers, Charles Myers from
Yeah, we all know who he is.
Yeah.
Gabe, yeah.
Well, years ago he there was a list, I still have it, that he recommended certain dosages, right? Just recently I did have my D3 tested,
Mm-hmm.
and it was in the level, I think it was close to 39 or 40,
Okay.
which is a safe level.
Mm-hmm.
And then I had my calcium just recently tested, and that's normal.
Mm-hmm.
And I had a bone density test just
Mm-hmm.
done, and that was normal also.
Okay.
Not any one side or another.
And you mentioned that in late 2015 that they found these bone mets in your spine. Have you had any scans since then?
No,
No.
no,
Okay.
no. I didn't think it was necessary because I was concerned about the side effects of the testing itself. However, now I think it's appropriate.
Okay.
As long as my PSA was low, very low. I mean, under 1 or undetectable. I didn't think I needed anything, but considering that for the last 6 months or so, it's been, let's say, average 1.5,
Mm-hmm.
that it would probably be appropriate now to get a new bone scan.
Well, there's a lot of stuff going on here. Let me just clarify a couple of other things for myself and for the guys on the call. If I got my numbers right, it was around 2000 that you did radiation, salvage radiation.
Let me see. That was that 17 years ago? Yeah, about then. Right.
Okay. And when they did that radiation, did they just radiate the prostate bed, or did they radiate across the whole pelvic girdle? Do you know?
You know what? I really don't know.
You don't?
I really don't know. It wasn't radiation at that time wasn't as sophisticated as it is today.
Right.
I essentially trusted the people that were doing that.
Right. Was it done at a center of excellence, or was it done locally?
No, it was done locally.
It was done locally.
Yeah, but the recommendations were high.
Right.
So.
Well,
Anyway.
I mean, certainly you're intervening. One would think you're intervening early enough. One of the big problems is that PSA isn't always the best indicator when you become metastatic. Have you been measuring your alkaline phosphatase?
What is the symbol for that?
ALK or ALP?
No.
Okay, so that's a very important marker because that gives you an indication of the bone activity. And and when you see that bone activity, you kind of at least start to get a feel what how active your metastasis is. Somebody reminded me, and I forgot to ask you. It went through my mind, and I forgot to ask you. What was your original Gleason score?
My Gleason was 7.
Was that a 3+4 or 4+3?
It was a 4+3.
Okay. So, I think there's more information that you need, and there's some simple stuff, but and I have some thoughts as to what I would do if it were me. But what I'm going to do is just open it up to the guys for 10 minutes or so, and then I'll try and summarize, and if you don't have any guidance from those who are on the call, then I'll try and pull it all together. So let me open it up. Who would like to start talking to Gabe and giving him some indicators?
Gabe,
Yes.
how did you find the Mets? Did you have a PET scan recently?
Actually, what it is, I was always annoyed at, like at the Lupron. I'm very active. I'm actually competitive in sports. I still play basketball, believe it or not, and play golf. I run. I do a lot of things, and maybe I can get better, without the Lupron. So I went to Dr. Stein at the, I guess it's called now the Rutgers Cancer Center in New Jersey, and I knew Dr. DiPaolo from years ago, and he said this is just before he left New Jersey, and he said, you should have a bone scan. So I had a bone scan, and that's when the Mets were picked up. But I was hoping that maybe I could get off of everything and lead a more normal life physically.
Well, if you've only got a few, if the bone scan picked it up, that's means there's something probably there, because bone scans are not the most accurate, but if it's picking up something, you might only have a few spots, and you might be able to deal with it with a good radiation oncologist. Just do spot radiation, CyberKnife or something, and then go on. I would, if it was me, I would get a good medical oncologist on the team that you can consult with and trust, that would really stay on top of this, because you might need second line anti-androgen. You might need to go on something else. But and they talk to you also about whether you can zap the Mets while they're small and few.
Yeah. Do you suggest that I have another bone scan now?
No, I wouldn't do a bone scan. I'd talk to them about a higher tech scan like Oxymin or something like that that's covered by Medicare, and you can do that someplace in the East. There's plenty of places.
I don't know. I've never heard of that. Can you spell it?
AXUMIN. I'll put it in the chat window for you since you're on the computer. AXUMIN. And that is, now, depending on where you go for treatment, they may have more sensitive than that, but that's a pretty sensitive scan. Amongst what's out there today, it's probably the third or fourth best that's available. And as Peter correctly said, it is covered by Medicare. Would anyone else like to chip in or talk to Gabe or have some thoughts or suggestions?
Well, Richard, may I ask you a question? You say it's like the third or fourth.
Yep.
What is the first?
The first is it's called an 18F PSMA scan. It's kind of hard to come by. There are a number of centers around the country that are doing it. You might possibly qualify. You need a PSA in excess of 2. It's kind of crazy because it's such a sensitive scan, but the way the trial's been set up, as I recall, you need a PSA in excess of 2, and you need to have a site that is biopsyable within 2 months of getting the scan. And that might be more of an issue because depending on where your metastases are, if they are in sensitive places around the spine, you might not be eligible. But I think it's being done, and I can send you the trial for that, and consensus is that that is the best that's available. It is a scan that is based on identifying prostate-specific membrane antigen, which means that it will only, the contrast will only pick up cells that feature that antigen, which are mostly prostate cells, but not only prostate cells. Now, that's the best. The second best is something called gallium-68, which is also a PSMA scan.
How do you spell that, Richard?
Gallium is Gallium.
Gallium.
68.
Uh-huh.
And that is the second best, and that is going to become commercially available right now. It's basically been in trial, and it has been accessible at the centers of excellence, but there are some radiologists that are going to be using that scan starting in January. The question is whether you can get it covered by Medicare or not, because otherwise it's going to be pretty expensive. And then the third best, I would say, is the Axumin, which is covered, and that works with. I think it might work. Peter, you know better than I do right now. I think it might work with the same contrast as the 18F PSMA scan, but but it's not only sensitive to prostate cells. Peter, do you know what the contrast is for the Axumin?
It begins with an F. Let me see.
I think it's the same thing. I think it's that same 18F contrast, but I'm not 100% sure.
Now, if I can interrupt, what now these number 1, number 2, number 3 scans, what do they show in addition to a standard bone scan?
Well, it's not. It's not that they show anything different, but they show at a much finer level. So you might not see something on a regular bone scan until there are something like 4 billion cells aggregated in one spot. But these scans will indicate metastasis at a much lower level, so at a much lower pickup of cancer, intensity of cancer. So you may see, you may not need to have as high a PSA. The PSA doesn't always indicate how much cancer you have. There are people like Jim Harrington who have a lot of cancer and a very low PSA, and there are some men who have a very high PSA and very little cancer. So
Right.
we can't always rely on PSA as an indicator. But I just want to ask a couple of other guys. But the one thing I will say to you right now is, you need to know about these things. But I don't necessarily think you should be making the choice. You, as Peter correctly said, and Jim, you need to find a quarterback, and you need to really start working with the quarterback. You've got to move the decision making to a joint process between yourself and a doctor that you trust. You need to know the questions to ask that doctor, and we can help you with that. And we can educate you so you ask the right questions. But if you've got a doctor that you like and you trust, between you, you're going to come up with the right sort of scan.
Okay.
Yeah.
I don't quite understand at this point, the difference in the scans. If they said I have a bone med, what difference does it make whether it's a finer tuned one or less than finer tuned?
Because you need to know where all of these hot spots are. And you won't see them if you just go with a regular bone scan. It will only pick up the spots.
So there may be other may be other
right.
hot spots.
There could be other hot spots in your lymph glands and in other spots which you wouldn't see, but these better scans are going to pick up a lot more activity. than the old sort of scan that you had 2 years ago would see.
Right.
Right. At this point, Gabe, the name of the game is you want to have as few Mets as possible, preferably under 5 or under, and you might be able to get treatment for it. And the bone scan's not going to tell you that fine a detail. A better scan will tell you that, because if it's more than 5, you're going to have a whole different treatment regimen than
I got it.
5.
So is there anyone else that would like to chip in and suggest some ideas to Gabe before we kind of pull it all together for him?
Yeah, hi, Gabe. It's Larry Fish.
Hi, Larry.
I had a question. You mentioned that they called the Mets holes.
Yeah.
Did that mean, did they say something like the lesions were lytic lesions rather than deposit lesions?
I don't know, but from what I recall, I have the report, in my file here. But what they said was there's a lot of little holes. That's what they said. A lot of little holes. So the impression that I had at the time, it wasn't like, wow, that's bad. It's just like a lot of little holes. So I absolutely have to do more research on that and find out what they mean by a lot of little holes.
And you don't know, did they classify you as oligometastatic, or did they just say metastatic, or they didn't specify that? Whether it means it was localized metastasis, or it might be a more broadly spread metastasis, the kind of thing that the guys are talking about, the scans would pick up.
Yeah, I don't know. I have to do more research. Yeah. Like I said, it was not a large issue for me because my PSA was low, and every time I took Lupron, it would go lower. It would go to 0.
And you weren't in pain, notice in your spine or anything? Okay.
No, other than the normal pain of being 75 years old.
All right. Thank you. I agree with the guys. I think that it's time for getting a real high-level professional medical oncologist to at least take a look at everything and to discuss things with. I'm with the general opinion here. Thank you.
Yeah.
Anyone else like to say anything before we move on?
Yeah, this is Alan Moskowitz. Just a couple of comments, if I could. I've been researching all those PET scans because I'm in the situation where I'm probably going to have to do it after failed prostatectomy and failed radiation. And so I just wanted to suggest to the gentleman is that one is I do have an article that briefly summarizes and compares those top scans that Rick mentioned. I'm happy to forward that to maybe Rick, or you can distribute it online or something. But there is the gallium scan. What I've seen online is that it's available in a clinical trial, but very easy to get into. You might be good, and that's at UCLA. You all may be aware of it. And you have to pay something out of pocket, but it's only about $2,500. It's not a huge amount of money. And that's one option. The fluorine scan that was number one, so to speak, that was mentioned. I don't recall all the particulars because I don't have it right in front of me, but NIH in Washington or Maryland, as well as Johns Hopkins, are doing those scans. Again, there may be certain requirements, etc., but you could do a little bit of research on that. And in terms of the Axeman, I know that one of the hospitals in New York City, I forget if it's Lenox Hill or Mount Sinai, one of those, not Sloan Kettering, but one of those two, I believe, offers Axeman. And so, I mean, these are all, I mean, from what I can understand, these are all great ways to proceed because, as someone said earlier, you want to know where all those hot spots are before you begin any sort of treatment on them.
Yeah. Well, thank you very much, Alan.
So, we need to move on in a few minutes. So, because we could keep going on with you for another hour with this group, and there's lots of great ideas. But there's a few things that I'd like to that I'd like to suggest. I am going to, since you have your computer open, I'm going to share my screen because I want to refer you. I want to refer you to something. I think. Tell me, guys, can you see? Do you see the screen? Do you see a screen now with some links on it, or are you looking at my mountain?
I'm
We're
looking at
looking
your
at
mountain.
the mountain.
Are you looking at the mountain? Okay, so because I have two monitors, I'm going to switch monitors then. Okay, monitor one. All right. Now, do you see some links?
Yes.
Okay. So this is from our web page, Gabe, which is at ancan.org, ancan.org. Again, somebody, Jake, would you put that in the, please put that in the chat window for us? And it's under prostate cancer links. Now, I don't know exactly which article Alan was referring to, but it might have been this one here that I'm pointing to that says PET scans for prostate cancer, which was written quite recently by Alan Edel, who I know personally. He was an excellent advocate and pretty technical. And if you click on that link, it'll give you a good explanation of all these scans we've been talking about. It's not going to necessarily refer you to the clinical trials. We can help you with that, or you can do your own research. But if you know at least the proper names, et cetera, you'll be able to start tracking down where these things are available. We know where some of them are available. We don't know all of them. So I strongly recommend that PET scans for prostate cancer article. There are some other things on here that I also recommend because based on how much radiation, how much metastasis you have, and probably the starting point is you will need to get one of these scans. As Peter correctly said, you've got a few options. You may be eligible for spot radiation, although a lot of times spot radiation doesn't always do it's not always successful. It can certainly retard the growth of the disease, but it doesn't cure the disease. Now, the other big issue is if they feel that you are now castrate resistant, you have some other options moving forward. One is Provenge. If you've had 3 successive increases in your PSA, and you've certainly had 2, then you're going to be eligible for Provenge, and that is paid for by Medicare. And that's a really good starting point, especially where you are now with a very low tumor burden. The earlier you can get your Provenge, the better you are. It is definitely something you would want to talk to your doctors about. You will probably get pushback if you go to Memorial Sloan Kettering just because they don't do it, but it doesn't mean you can't get it somewhere else. And there are people like on this call that have been through that. I wouldn't allow it to eliminate Memorial Sloan Kettering, but I would say that if you do go to Memorial Sloan Kettering, you need to find a way to get Provenge, or at least if it were me, I would also be wanting to get Provenge as early as I could. Jim Harrington has done that treatment. Other people have done the treatment. It's an easy treatment to do. Few complications for most people. Occasionally there are some issues with it. Again, we'll talk you through it when you get to that point. The other big issue is, as you probably know, what we've seen in studies recently is that the earlier you intervene with either a second-line anti-androgen or chemotherapy, the better you are. Now, chemotherapy is probably the best thing based on the trial results, but at the same time, we know that either Zytiga or Xtandi, that's abiraterone or enzalutamide, is also very good. If you look again here, there's some great discussion of that in these first 2 links, abiraterone Zytiga versus enzalutamide Xtandi. There's a comparison which is the best, and then this second article, Zytiga extended or chemotherapy first, is a very good discussion by these three docs, and you'll learn a lot from it, and it'll put you in a great place when you go in and you meet with whichever doctor it is that you choose. So that's another, particularly this second one, Zytiga extended or chemotherapy first. I would strongly recommend that you listen to that. It's about a half-hour discussion. It's worthwhile. I think, as the guys have said, and I've said, you've got to pick a genitourinary medical oncologist to lead your charge here. And the options in New York are either Memorial Sloan Kettering or Columbia Presbyterian. And Dr. Stein, as you probably know, is going to be at Columbia Presbyterian, so you could go back and see him, or one of the other GU medical oncologists there. We know a number of good docs at Memorial Sloan Kettering. The one that we often recommend, because she has a very good bedside manner and she is relatively easy to get an appointment with, and she gets great marks from Jim Harrington and many others, is Dana Rathkopf, Rathkopf, Dana Rathkopf. I know that Larry likes his doc. Isn't it Karen Audio? Is that right, Larry?
Yes, it's Audio, AUTIO.
AUTIO.
And you can read her website at Sloan and see the research that she's in, sometimes with Diane, sometimes separate. I find her really good for me.
So, those are
a good teammate.
Those are two names. I mean, the more popular, the more familiar names like Michael Morris and Howard Scher can be difficult to get appointments with. I can refer you to people that have seen them if you want to get a better feel. Personally, if it were me, I would avoid Susan Slavin. She doesn't have a great bedside manner, and several people have found that they just don't get the time with her that they like. But it's a bit of a personal taste. As far as the doctors at Columbia Presbyterian, we know that Charles Drake is there. I don't know if he sees patients or he doesn't. And certainly now Mark Stein is going to join him. Let me ask the guys, is there anybody in the greater New York area that we've, in the tri-state area, that we've missed that we should mention?
This is Alan Moskowitz. I don't know if he's a leading person, but when I went to Sloan a couple of months ago, and I couldn't get appointments with some of those top guns, I was referred to a Dr. Yu Chen, Chen, and I got a whole lot of time with him, and I was very impressed with his knowledge. So he might be one. I mean, I only went once, and I spoke to him on the phone a couple times, but if you need another name, maybe that's one of them.
So I'm hearing that you're really not recommending the New Jersey Cancer Institute or Rutgers Cancer Institute down here, huh?
If it were me, it would not be my choice. But, maybe Jim Harrington wants to chip in on that.
Well, Rick, it's true that Dr. Stein is leaving and going to Columbia Presbyterian. I really can't recommend. I have Dr. Mayer there who takes over, and that's where I have my infusions, and I'll continue to have them. I'm not going to go all the way up to Columbia Presbyterian just to get docetaxel. So I really don't have any other suggestions at the Cancer Institute. Other than it is a good place to go, and I've seen Dr. Mayer once, who's Stein's colleague, but I think your recommendation to go to MSK and Rathkopf is really good. He's very, very good. So I can't recommend anybody now that Stein is leaving, because I'm going to go see Stein at Columbia Presbyterian. So I really have no recommendation for the Cancer Institute. Even that's where I go. You know.
Mm.
Yeah, thank you.
Okay.
So I have put my email address in the chat window for you, and you'll see it there. It's also on the email that Jim forwarded to you. You know, if you want to reach out, we're happy to help you. The way we usually work is that these calls are free and drop in. And if you feel inclined to make a donation to the nonprofit afterwards, it would be much appreciated, but we don't require it. We do ask you, if you would, to sign up for Amazon Smile, because it doesn't cost you anything and we benefit. If we do individual navigation, we do ask you to make a donation. And we can talk about that offline. We have a recommended rate, but we don't turn anybody away. So, you know, but we do need you to make that commitment if you want us to work with you individually. But we meet every week on these calls. So, you know, if you would prefer, you can just come back on next Tuesday, and you know, we'll update you and continue to guide you. So it's really your choice how to proceed. But in the meantime, if there's anything that you would like clarified from this call, please feel free to reach out to me, and we'll do it. We'll take care of it. We also will, when you do that, we'll add your email to our distribution so that you'll know every time when we're going to have a call. You know, I keep a record, so I'll put you in. Where do you actually live, Gabe?
I live in Blairstown, New Jersey.
Okay.
Which is about 60 miles due west of New York City.
Okay. Yep. Okay, so you know, email me anyway, so I have your email and I have your last name, and hopefully this has been helpful to you, and you can see what you can gain out of being in this group. I don't
very good.
It's
been very helpful. Thank you.
Pleasure.
Thank you all.
I just like to add congratulations for managing your disease, diagnosed early for 21 years.
Yeah.
That's pretty amazing.
Yeah,
Well,
I agree.
Thank you very much. Yeah. And I have, it doesn't matter, but that's fine. We'll talk more.
Yeah.
Gabe, just for clarification, if you want to join us next Tuesday, it's at 6 o'clock your time. Today is 8 o'clock your time, but the Tuesday meeting is 6 o'clock your time. Just so you don't tune in too late.
Well, I'll pop over an email to Richard, and then I'll get the schedule.
That's perfect.
I'll figure out how to speak to my computer. Okay.
The other thing is that I know I don't. It doesn't sound like you need it, but we should tell you that we run the inner conversation call, and since Jake moderates that call, do you just want to give a quick a commercial for the inner conversation call for Gabe?
Sure. My name's Jake Hannum. Every second and fourth Thursday, we at this time, 8 o'clock Eastern time, we have what we call inner conversations, and we try to stay very specific. We try to stay away from the technical aspects like we talked about tonight. You know, Rick goes into all the nitty-gritty details. What we try to talk about is the emotional side of prostate cancer. Yeah. You know, how does it feel? You know, how does it make you feel? Are you angry? Are you sad? Are you really pissed? You know, and a lot of times sometimes we have a you know, very in-depth and heart-wrenching conversations. Sometimes they're very lighthearted. Gary can attest to that. I think probably our caller number 8 is Sylvester. If I know Sylvester, is that you, Sylvester?
Yes, I'm on here. That's
I know it. Sylvester joins us. Gary joins us. So you know, it's a good call. We usually end up feeling better afterwards. We're not going to be able to answer the technical stuff like Rick just did for you, but we'd love to see you.
Okay. All right, Jake. Jake, thank you.
Tuesday and second and fourth Thursday of the month at 8 o'clock.
Okay.
Your time.
Thank you.
You're welcome.
Okay, so we'll move along here. Let me see. I'm trying. Oh, here, this is what I'm seeing. My attendees. Do we have? Is there anybody that we have not welcomed? I don't think so. No. Oh yes, Art. Hello, Art. Art is on as well. So.
Eric, everybody.
All right, so I'm just going to run down my list and then just tell me in case I missed anybody. Peter Kafka, Jim Harrington, John Appler, Alan Moskowitz, Jake Hannum, Dennis Correa, Thibault Lincecum, Eric Bookbinder, Gabe, Paul Frieda, Gary Gunman, Bill Franklin, Larry Fish, Sylvester, and Art Boosie. Did I miss anyone? Good. All right. Let me run down and see who would like some time. We still have a whole hour left, so hopefully we can get around a bunch of people. Peter, anything for you tonight?
I think I'll hold it for another time. I'd like to hear from some of the other guys.
Okay. Jim Harrington, anything for you?
No, thanks, Rick. I'm glad that Gabe called in, but no, I have nothing tonight.
Okay. John Appler, anything for you? John, you still with us?
I think he dropped off, Rick.
Okay. Alan, I know you would like to talk to us, and you can fill us in because we haven't heard from you for so long. It's good to hear your voice.
That's right.
So,
That's right. It's a long time, and I'm not going to take up too much time.
That's okay.
Yeah, I know we moved in within New Jersey and all. There's too much going on, and
Okay.
I really didn't have a lot to talk about. So here's the deal.
Okay, hold on.
Yep.
I'm just checking to see who needs time, and then we'll come.
Oh, sorry.
Okay. Jake.
Sorry. Yep.
Jake, anything for you tonight?
No, Rick.
Dennis, how about yourself?
Give me about 2 minutes.
You got it. Is Thibault still with us? Because I know Thibault's definitely has some stuff.
No, he dropped off.
He did drop off. But
Yeah.
for those of you who did not hear right at the beginning, it looks like Thibault's going to start his bone marrow transplants very soon. And I'm sorry, I should have really gone to him first because I know that with the kids, he sometimes cannot stay. And I will reach out to him for sure. But he told Jake and myself that for the next 30 days, he's going to be getting these bone marrow transplants. So he's moving forward with that treatment. Eric, are you with us?
Yeah, I'm here.
Okay. Would you like some time tonight?
Yes.
Definitely. Paul Frieda, anything?
I'm good. Nothing for me tonight.
Okay. Gary Gunman, anything for you?
Just listening tonight.
Okay. Mr. Franklin.
By the way, Rick, that's Gary Gunville.
Oh, Gunville, sorry. Okay. Sorry.
I'm sticking up for you, Gary.
Okay. Bill Franklin, anything for you?
No, I'm good tonight, Rick. Thanks.
Okay. Larry Fish, anything for you?
I'm okay, thanks.
Okay. Sylvester Mann, anything for you?
No, thank you very much.
And Art Boosie, you want to give us a quick update on how you're moving forward because you are making progress.
Not really tonight. I had so much good time last week. I do have one question about ALK since you brought it up.
Okay.
There's time. We'll see.
We will hopefully we'll have enough time for you because right now it only looks like there's 4, so we should be fine. Okay, Alan, you are up.
Much. So here's the 1 minute background. I had a prostatectomy back in March of 2013. Gleason 7, didn't have any bad pathology, and the post surgery PSA went down to, let's call it 0. And I was good for 18 months. I started to get a recurrence, and when I hit about 0.1, I opted for 6 months of hormone therapy, roughly concurrent with IMRT radiation, and I had about, I think it was 67 grays over 37 or 38 sessions, and all of that was done a year ago last May, right before Memorial Day of 2016. I was done. And so, of course, it took a while for the hormone therapy to sort of wear off, and unfortunately, though, my PSA started to creep back up at the beginning of this year. And so it has gone up about 0.1 units every 3 months. And I just got my results this week from my PSA last week. And I predicted it right on the money. It's now at 0.4. And so if I look at the last 3 data points, my doubling time is about 5.3 months. If I go to the previous 4 points, then my doubling time drops to 4 months, not 5.3, goes to 4. And if I count another earlier point, then the doubling time would actually be closer to 3 months. So my conclusion from that is doubling time is sort of increasing a bit, and then let's say it's hoping it stays around 5 months, or give or take. So now I did see Dr. Chen at Sloan Kettering. I talked to him. He went through the whole story. I don't need to go into details, but basically he said, look, typically intermittent ADT would be the most likely treatment, but he was okay if I wanted to do one of these PET scans. Now, Sloan Kettering, I don't think, although unless something's changed in the past few weeks, they didn't have a scan that was necessarily suitable for me. I don't think I'd qualify, but I have hunted around a bit online with the clinical study sites, and I have found some things that might work. UCLA had the gallium scan, and the as I mentioned earlier, Johns Hopkins has something, one of the fluoride scans, and NIH. And so, and Axemin, in New York City, I could have Axemin. Now, I'm not Medicare age, but I'm not much concerned too much about the cost. I mean, I have insurance, whatever it'll cover. Most of the clinical trial stuff, it'll be out-of-pocket charges. Doesn't seem to be a big hurdle. My question, and here's the hard part, how am I going to decide, all other things being equal, which scan, in other words, which tracer, which radioactive component is worth getting? So, sure, there was the same article that Alan, whatever his name was, that's the one I sent to you, Rick, which is the one you had on the website, same one. Yeah, they like the fluorine ones, the F-18, and they have more sensitivity, and that would be fine. And my gut feeling says go with the most sensitive one. But then the second question is, how high do I go on PSA? I mean, I'd like to only do it once, not to have to go through it twice, but that might mean letting my PSA go from 0.4, maybe a 0.6 or something like that. I don't really need to go to 1. Or do I make life easy, go to wherever it is in New York, get Axemin scan? It's less sensitive, not as good, very convenient, right? Or do I go out to UCLA? I can have the gallium one and all. And so, assuming my medical oncologist doesn't offer a real suggestion and maybe leaves it up to me or lets me make the first cut, how am I going to make that sort of decision? Do you have any thoughts? Does anybody have any thoughts? Am I going with the most sensitive? Do I do it sooner rather than later? Or do I want to increase my chances of success by stalling and let PSA go up a bit more?
So I would say that yes, there is at least one person on this call who has some thoughts because they're dealing with the exact same issue. So I'm going to let that one person kick it off. Peter, go ahead.
Okay, so I'm in the same situation you are, Alan.
Okay.
In consultation with my genitourinary oncologist on the West Coast, our agreement is that I'm going to wait until 0.5, so at least it gets up to 0.5. And Oxymin recommends 0.5 to 0.7 to do an Oxymin scale. So that's where I am. And mine's a 2-month doubling time, and I figure it should reach 0.5 to 7 by February. And I'm going to fly over to California and get an Oxymin scan then. And we agreed that if by any chance the Oxymin scan doesn't pick up anything and shows no record of any activity anyplace, then I can always go to a more definitive scan. I mean, I hear you about not wanting to get too many scans, but I suspect that the Oxymin scan will pick up something because I've got a 2-month doubling time for the last 3 months, 4 months. And I'm a little bit lower than you right now, but it is on the move. And I'll probably have to go on some kind of second-line anti-androgen as well, or as well as Lupron. So that's where I am with this.
What was there a thinking? This is Alan. What was your thought process on going with Oxymin? Did it have to do with the fact that it's covered by Medicare or insurance? Was that a factor at all?
That's part of it. I live in Hawaii and I have to fly to California and absorb that cost myself. So
right.
Yes, that's part of it. But everything I've read about the Oxymin scan shows that it's pretty darn good. It's not the best, but it's pretty darn good. It's a lot better than a CT scan or a bone scan or anything like that. And it does pick up some pretty fine detail. So that's where I am with it. I'm not hunting for it's not a question of where's Waldo. I have a pretty good feeling that we're going to find something.
Yeah, does it? And I'm asking these questions not to challenge your decision, so please don't take it the wrong way. I'm asking because I'm trying to make a decision, and these things are on my mind. I mean, UCLA has the gallium scan, right? It's California. You could pay $2,600. You could have a scan there, and it might pick up multiple spots that perhaps someone might miss. And I don't know, did you consider that at all, or did you just say you'll go with the sort of the approved scan, nothing in clinical trial, and then go from there? This is sort of what I'm hearing.
I don't think I don't think I'd qualify for a clinical trial. I looked at the regulations on that. I don't fall in that. I'm not necessarily resistant at this point. I've been off of Lupron for a year, and I didn't fail Lupron yet. So I don't know. Maybe Lupron will still work for me, but I'll probably go back on Zytiga when I go back on. So
have you only had 1 year of Lupron, and that was it?
No, I had 18 months.
18 months.
I've like you. I've had radiation. I've also had surgery. I've been through the mill, so I've had this stuff, but I've had a year vacation, and I'm ready to go back at it again.
Yeah. Okay. Yeah. All right. That's very interesting. Thanks for those comments. Rick,
Alan, a couple of things. I just put in the chat window for you, and you may have seen it, an article that, or a commentary that was posted on prostate cancer info link, written by Alan Edel last week. So it's a little more recent than his article. And there's a lot of what's in the article, but if you haven't seen it, it talks about the what sort of level you might get a result if you did a gallium 68 and some other things. So it's just worth going
Okay.
through. I don't remember all the details of it. I read it last week. I remember I saw it. I need to reread it myself. So
Okay, good.
I think it might be helpful for you. Secondly, I kind of I like Peter's approach, which is because the Axiomin is really the low-hanging fruit, and for you in particular, it's easy to do. It might not be a bad, and it's probably covered by your insurance. It might not be a bad place to start.
Yeah. Yeah, no, there's a lot of merit to that. Absolutely. This has been on my mind, and it's easy, it's close. The doctor at Sloan Kettering, he says I refer people over to whichever hospital it's at. He said it's very simple, a prescription, and yeah, it might be worth doing and see where I am. And if the levels, I'll have to say,
Sorry about that.
Whoops.
Go ahead.
It's all right. I'll have to just double check the levels in that original article and just to see how high or how low it could be. But I'll be at 0.5, I'm sure, in 3 months and all. And so I will consider that. I think it's maybe a very good suggestion. Certainly the easiest, and hanging fruit is right.
And don't be a stranger. Come back to us, particularly if you're, seeing different doctors. Come back to us. Stay in touch with Peter. Come back to us and talk to us, and let's keep supporting you.
Yes, thank you. I'll do that. Very good.
Anybody else? We asked Peter. Has anybody else got any ideas for Alan on these scans? No? Okay. No.
Very good. Thank you.
Okay. All right. So, Dennis, you are up, sir.
Yeah, I'm here.
Okay.
Just a kind of a thing that happened to me this weekend. I thought I was coming down with a cold, and it progressively got worse pretty quickly, and it caused me to have a fever, and it exceeded the point of 100.4, where they tell you need to very quickly contact your doctor and let them know that may require immediate treatment. So, of course, these things always happen late on a Saturday night, and unable to get my doc, and end up with somebody else. And short story is, get to the emergency room. So I got to the emergency room late Saturday night, and they did all the tests, confirmed it wasn't the flu, that it wasn't pneumonia. They did x-rays. So after about 4 hours in the hospital, they said you got a virus infection. So just go home and treat the symptoms, But I think, and I looked back at the prednisone paperwork on the drug facts, and it does say that it can cause you to be more prone to an infection when you're on the Zytiga and the prednisone. And I looked back on my activities. We had a lot of holiday parties going on and stuff, and crowded rooms and shaking hands with everybody and that kind of stuff. So I probably picked up something there. I'm recovering from it almost as quickly. I'm knocking on wood. I'd say I'm recovering from it. I hope it's on its way out, but I have coughing pretty bad and spitting up and all that good stuff. But just a side effect of that.
I think, first of all, the most important thing, has it put a crimp in your golf game, Mr. Correa?
Yeah, it did. I canceled my golf game today.
Oh, yeah. Well, that's
it's for next Thursday too. I want to make sure now our daughter's coming to visit over the holidays, and I just want to be sure I got to get rid of this thing.
Yeah.
So I'm just going to take it easy and loaf around.
But you do raise a very good point, which is that you guys who do have fairly advanced disease, your immune system is compromised. It can be even more compromised, as Dennis says, when you're taking some of these steroids. And you do need to be sensitive to that. And probably that's exactly what happened. You were, with a bunch of people and shaking hands, and so I'm not suggesting that you all become hermits, but I am suggesting that you watch out and you be sensitive and aware about it, because it is
Even Hermes can
important.
even Hermes can get sick, Rick.
Say that
Even
again.
Hermes can get sick.
Oh, even hermits can get sick. Don't
Yeah,
tell me.
I leave the house once a month to go to the doctor, and sure enough, I come back with a cold or something.
Okay. Well, that's probably because you're even more sensitive. You don't get
That could
out
very
enough.
well be.
Yeah. Well, I'm glad that you're recovering as quickly as you went down, Dennis. I'll give you a call in the next day or so, and we'll talk.
Okay.
Anybody else have any thoughts on this compromised immune system over the holidays? Suggestions, ideas? Quiet bunch tonight.
Stay away from the sweet stuff.
Oh, yes. Very good. Very good. Good advice, Peter.
Absolutely. There's too many sweet stuff temptations being passed around,
I know. Watch that sugar, guys. Watch that sugar. Okay. Eric, it's good to hear you on the call. Tell us how you're doing. Have you been to see Agarwal yet?
Okay, so I went in actually, I spent 4 days in the hospital before that. And they thought I had pneumonia. I went in because my blood pressure was 73/45. And they didn't think that was compatible with life. So they put me in the hospital and put me back on steroids, which I was almost off of, and monkeyed around with all of my meds. They did a chest X-ray in the ER, and they thought I had pneumonia from that one. But 2 days later, they did a better chest X-ray and said that what they thought was a shadow in the lung had disappeared. So then they decided I didn't have pneumonia. In the meantime, they'd been pumping me full of antibiotics. So who knows what that did to my system. But they finally sent me home, and then on the 12th, I had an MRI, and I was in the tube for 2 hours and 45 minutes. So, but they had scheduled my appointment with the radiation oncologist at 2 hours, and with Aguilar 2.5 hours. So by the time I got to the radiation oncologist, luckily they called me and asked if I was still coming and waited for me. So I had gone in at 1:30, and so it was 5:30 when I got to the radiation oncologist. And they said that the palliative radiation had done what it was supposed to do. It cut the tumors away from the spine, and that the tumors were the same as showed no growth from the previous MRI, which was like 2 months before. So on that basis, they recommend that I continue on the chemo that I'm on. So rather than stop that and going into hospice or doing whatever. Oh, so of course I totally missed the appointment with Aguilar. I've rescheduled for next week. So I have an appointment with him, and I'll discuss everything. But in the meantime, I'm going to continue the chemo that I'm on right now, which is Geftana and carboplatinum, whatever it's called. So in the hospital, my blood pressure kept going up and down, and then it went way up, and then they finally decided that it was in an okay range when they sent me home. I went into my PCP today, and he couldn't get his old-fashioned mercury blood pressure machine. He got that my blood pressure was 90/75. Now, I've been taking it at home, and it has not gone below 108/80. So I don't know what's wrong with his machine. I'm pretty sure mine is accurate because I've compared it against the manual ones when the health at home people come.
Right.
He wanted me to go right to the emergency room, but I called the cancer center in Berkeley and talked to them, and they, told the whole situation. And I took the blood pressure again when I got home, and it was 125/90. And they said, well, as long as you monitor it and it stays there. And I don't feel bad. When my blood pressure was way down, I couldn't even get up. Mm-hmm. But I'm walking around, I'm doing everything I want to do. So I think that it would have been an unnecessary trip to go to the emergency room. But I'll keep an eye on it, and I'm having my next infusion is on Thursday, and I see Aguilar. I'm not sure where, but somewhere within the next week I see Aguilar and Agarwal.
Right.
I think just going to stay the course right now. I feel so much better than I did, before I went into the hospital, which is reasonable since I now have enough blood flowing around my body to keep everything alive. So that's my update.
Well, I will say that not only do you probably feel better this week, but you sound a lot better than when we last spoke to you, which I think was 2 weeks ago.
Yep.
Way better. And as we said to you, you got to choose your quarterback, and you got to stick with that quarterback. And I think that Dolezal was just too quick to dismiss you, and it's a concern. Was Agarwal aware that you were? Does he know that you were in the hospital last week?
I think so. I got visits from several of the other doctors. I don't know for sure, and I didn't tell him myself.
Which hospital were you in? I should have asked you that.
Oh, I was not in UCSF. I was in Alta Bates in Berkeley.
Yeah, but you see, you got to make sure he knows. You got to let him know that you were hospitalized. And again, if he's going to be your main man, it's really important that you keep him up to date on issues like this.
Mm-hmm.
And then he isn't blindsided when you walk in and say, oh yeah, I feel much better than when I was in the hospital last week. And he says, in the hospital last week? Who knew? So,
right.
Use the My Chart and say, Dr. Agwal, I just want to let you know, I've been having problems with my blood pressure again. I know I'm seeing you, but he'll give you a call. If you need to talk to him ahead of time, he'll give you a call. And, plus the fact that this MRI that you did, and I'm delighted to hear those results, as I'm sure you were, Eric. But the MRI you did was at UCSF. And yet the infusion that you're going to do is on Thursdays at Outer Bates, correct?
Yes.
and Outer Bates are the ones that said we don't want to give you any more chemo. So, I mean, who is talking to who here? I mean, how is it that whoever your new doctor is, because it isn't Dolezal because she's gone, how is it that the information which was positive that came out of your MRI got to somebody at Outer Bates and Agarwal isn't even involved in this?
Yeah, well, that's an important point. I guess I will send him a note right now.
I mean, you given where you are in the disease, you got to have a quarterback, and I don't feel like you're really committed to somebody calling the shots. I mean, when you decided clearly what happened. I mean, I see what happened. They said to you, Eric, the radonc or the radiologist at UCSF who read the MRI said made a call that you could continue your chemo, which you wanted to hear. Who was that? Was it a radiologist or was it a radiation oncologist who made that call?
Radonc.
Which one?
His name is Bronstein.
Okay, yeah, I don't know him. But isn't he the guy? Didn't we decide that he was the guy that was the spine guy?
No, that's someone else. Yeah,
So,
I thought it was Bronstein. I'd have to look it up in my records, but that was another doctor who said that.
because I don't
Who's the
know.
spine surgeon?
Right. I mean, I don't know this. I mean, this radonc may be a guy that is a spinal radonc or an orthopedic radonc rather than a GU radonc. Because and what bothers me is, while it's his opinion, you could continue the chemo, and we would all love to see you continue the chemo. Everybody's pulling for you. It seems to me that you want either a GU radonc or a GU medonc making that decision, and not somebody who's. And clearly, you then, I assume, you then call up Outer Bates and you say, "Oh, I would like to schedule another chemo," and there's no pushback from them. Is that how it happened?
Yeah, it's already scheduled. They scheduled it a month ago.
Oh, they scheduled. Oh, so Dolezal didn't cancel all of your appointments.
Right.
Well, I mean, it's.
I had in my last discussions with her and the other people that were there, I had said I want to wait and see what this MRI shows before I make any life-changing decisions.
Great. But you got to get some. You got to get a quarterback, Eric. You got to get a quarterback. And
at this point, I think I'd rather get someone from UC, but I don't know who to go to at this point.
Agarwal.
Yeah, well, that's the intent. I don't know, that he's going to have enough time to commit to me.
Well, he has the time. He's been treating you for ages. He knows you. You have a good relationship with him. And, frankly, what I would do is call up there tomorrow, send him a note tonight, tell him you really need to speak to him tomorrow because you have another infusion scheduled for Thursday, and you want to make sure that he's on board because and he knows Dolezal, and you tell him Dolezal's gone, and you really want to talk to him about this. And then when you talk to him, you can say, "Look, Dr. A, you're my quarterback."
Mm-hmm. Okay. Sounds good.
I kind of feel like you're sort of getting bounced around here, and I really want you, especially where you are, I really want you to be working with someone who's on the money for you, and who has your best interests at heart, which I think Agarwal does. Are you comfortable with
Yeah,
Agawul?
I hope so. I'm just worried, that he has too much on his plate.
Well, he's always made time for you.
Yeah.
And, it's not like a situation with some of the other docs there where you can't get to see him. He's always made the time. And when I've run into him and said anything, he's always got good things to say. So I just think but you have to be your best advocate here, and you're not being, I hate to tell you, but you're just not being your best advocate. Anybody else? Let me throw this one again open. Anyone else want to say anything? Peter or Larry or anybody else? Jake? Okay.
So,
Eric,
anyone else going to UCSF that has a quarterback there?
No, but Eric, it's good to hear you. We were pretty concerned about you 2 weeks ago. At least I was.
Yeah.
I mean,
Yeah,
you did not sound well.
I felt like I was.
No.
Yeah.
That's what I was going to say too, Eric. I don't have any good advice other than what Rick gave you, but we were all concerned, and I was kind of thinking you'd be on the inter conversations call, but now I understand why you weren't. You're in the hospital.
Right.
So, but anyway, yeah, we're rooting for you, and we're glad that you're at least feeling better. And just please do what Rick says, and settle on one doctor and let him call all the shots. That's really what you need to do. Have one doctor who calls the shots and coordinates all the other stuff.
Yeah. Okay.
I mean,
I will do that.
The other thing, Eric, is that it's you sort of assumed Agawul through the clinical trial process, and clearly Amy Lim wasn't the right person. We all agreed with that. And you sort of slipped into Agawul's, you slipped onto Agawul's radar, and you've sort of stayed there, and you've been with him now, what, 2 years? How long?
Yeah, something like that.
So, if that's the case, then trying to switch docs is not easy. And I think that they would consider that Agawul is your doctor there. So even if I said to you, well, consider somebody else at UCSF, it's not clear that it would even be that easy. And you like him, he's a good doc. We recommend him. So, I don't know. I'm not really sure why you would tell us why you would want to look for someone else.
Only if he says he doesn't have the time.
Well, I don't think he's going to say that he doesn't have the time. I mean, that's my feeling. I just can't see why he would say that. And you're his patient. You're his patient.
Yep.
Okay. Anyone else want to chip in on that one? Make a contribution? Okay. All right. Well, look, keep us posted. Give us a heads up, for goodness sake. Let me know if you're in the hospital, if there's anything we can do for you. And try and get to see Agawul, at least talk to him and make sure everybody's on the same page. And we're all really, really pleased that you're doing better. notwithstanding the session in the hospital, but it's good to know that you're doing better.
I think so.
Send me those CDs whilst you're standing upright too, please.
All right. I haven't even pulled them out of the car yet.
You are on my list to send a note to as well, by the way. Thank you very much for your contribution, your donation. I will be writing to you personally. All right. See, we're doing good on time here. We've got time for Art and we've got time for Peter. Art, you had a question.
Okay. Yeah, you mentioned ALT and ALK.
Yeah.
And I went back and looked at my recent numbers on that. And ALT was normal, but my ALK is high. And my oncologist was not too concerned about that. I'm not sure why. I'm not even sure what ALK signifies, but I can tell you that on let's see, October 1st was 150, November 1st 500, November 17th 455. And they say the normal range is 37 to 117.
Right.
Kind of corresponds to my PSA, but I think with a lag. If it's about metastatic activity, I don't have any scans to make the comparison with, except for what I got last late spring, early summer. I'm due for another scan, but since I'm changing who I'm going to, I was going to wait till I got the UCSF for the next scan. So what is ALK all about? Okay,
so ALK and ALT is something different. To the best of my knowledge, that's a liver function test.
Right, that's what I think too.
ALK or ALP is alkaline phosphatase, and it is a measure of bone activity. It can sometimes be misleading because you can have bone activity both when the cancer is growing and also when the cancer is dying. So there can be times when it's confusing.
Okay, well, it went from 150 to 500 in the first, corresponds exactly to the first monthly Lupron shot I got. So that might mean that it was about dying.
And it could be that as your testosterone fell, some of the metastasis was flaking off, and it could explain a high ALK or ALP. But normally, it's a concern with most men if they've been, let's say they're castrate resistant, and so they've been on Lupron or LHRH for a long time. And you see a big jump like that in the ALK, it would be a concern that there was some metastatic activity somewhere.
Right. Well, I already know that I've got multiple bone metastases.
Right. Right. So. Anyone else on the call want to talk about ALK?
Rick, this is Jim Harrington. I've also had mine jump up. It's been as high as 300 or so. But one thing I want to ask you: are you anemic? What is your hemoglobin? Because what's happening is that, at least as I understand the alkaline phosphatase, is that it does. You're right. It does get into the bone, and it compromises the ability of the body to make red blood cells sometimes. And that's what happened to me. So I'm anemic. And but I'm just wondering, are you anemic? Do you know what your red blood count is?
I have been having my blood tested 4 things like that. The red blood cell count and hemoglobin were and are in the normal range, but kind of at the low end of the normal range.
Well, it sounds like you're okay. Not me. My hemoglobin went to 7.3. That's really anemic. But they give me blood, it pops up, goes back down, give me blood, and so forth. I've had lots of transfusions, and it's not uncommon for some of us with the prostate cancer, of course, to have transfusions. I just thought I'd mention it, but yeah, my doctor doesn't seem too concerned about alkaline phosphatase either. But I kind of wonder about it. It kind of goes up and down. But and if you're not, I mean, if it turns out to be that you're anemic or your red blood count, your hemoglobin that is goes down, then you should be concerned about it maybe more. But it according to what my doctor said is that it's the cancer that's causing this hemoglobin. So that's what is causing this. So anyway.
I read somewhere, and I can't tell you where, but just in the last week, that one should expect anemia as a problem starting 6 months to a year after ADT.
Yes, but minor.
It could be. I don't know. It could be. Maybe you're right. Yeah. It sounds okay to me.
There are two things going on here. One is that, yes, after you've been on ADT for 9 to 12 months, you do see anemia, but it's pretty mild. I mean, I know I certainly had marginal blood counts, but it wasn't excessive. It wasn't like what Jim is wrestling with. The other issue that gives rise to anemia, which is probably not your situation, is that as the cancer gets more aggressive, it can compromise the bone marrow, and you get what's called myelosuppression. And that is more likely what's going on with Jim and why he needs the blood transfusions, as opposed to your situation where we know that you have some metastasis, but it's not that extensive right now.
Right.
So
yeah, 4 or 5, I think, last summer.
Right. So probably anemia would not have been a result of the metastasis, but yes, just being on ADT without any metastasis, the lack of testosterone affects the way that the bone marrow works, and it doesn't work as efficiently, and so it doesn't produce as many red blood cells, and that can be compensated for by exercise and other things too.
Mm-hmm. Okay. This probably satisfies me on the ALK question, ALT.
Yeah, I mean, my guess is that I don't know. I'm not a doc, and it's a hard one, but I think the only reason why they probably didn't comment on it, because they would have noted that it was pretty high, was that maybe they tied it into the lack of testosterone.
Mm-hmm.
But I don't know. When was the last time you had your ALK measured?
Let's see. Would have been the middle of November.
And when did you start? You started the Lupron in October.
Yeah.
So was that November one the one that was 500?
Well, went up to 500 November 1st.
Right.
And it's now well, and then at the middle of November was at 455.
Okay.
Before the 500, just 1 month earlier, October 1st, it was 150. So there was a big jump in that 1 month.
Right. But what about
first month of Lupron?
Have you done any blood work in the last? It's a month since your last blood work. Have you done anything since?
Really just looking at PSA.
I would get some blood work. If the last blood work was 450, I would get some blood work. If it were me,
Yeah,
I'd
that's
want to
what
know.
I asked my aunt about that, and she declined.
Well,
She said, you don't need it.
you
Doesn't
tell her
change.
you want it because your ALK was 500 and you'd like to see if it's come down.
Right.
And again, you tell her that you want it. Don't ask her, can I have it? You say, I want blood work, please.
Right. Yeah, I know. And I went in asking for something like 4 or 5 things, and I got one last time, which is why I'm switching to a different oncologist.
Right.
But there was one thing that she added to the what they look for when I do my next blood test, and that has to do with the other kind of testosterone. Is it dihydrotestosterone or something?
Yeah.
Okay, so I was asking her that, watching my PSA has fallen off dramatically since I started Lupron, but the rate at which it's falling off has decreased in the last couple of weeks, the last maybe. And I asked her about that, and that was her response. Well, it's taking out most of your testosterone, but let's see how much of the dihydro.
Yeah.
Okay, let's see how much dihydrotestosterone you have. So I'm probably going to go in tomorrow and check that out.
Well, if you're going to go in and get blood work, send her a note tonight and say, I'd like to get some of my other blood work tested at the same time, please.
Mm-hmm. Well, okay, and which other blood work?
Well, the ALK.
Yeah, anything else?
You can get a PSA. But when was your last PSA?
A week ago.
And that was what?
18.
Okay. So it's
down from a high of 223.
Right.
233 at the beginning of October.
Right.
But it only fell 5 points from the last 2 weeks before that. It only fell off 5 points, which is why I was asking the question.
Probably from week to week it doesn't matter, but if you're there and you're getting it done, you might want to know where your testosterone is too.
Now I asked her that. That was one of the things I asked for, and she said, last time we checked it was 20, down from 770, and she said that their test is not sensitive to detect anything under 20.
No. But if you know it's down to less than 20, that's good. But you have to keep I believe that you have to keep monitoring it because you want to be sure that the Lupron is doing its job. In your case, it almost certainly is because you've only just started it. But it's always a good idea to make sure that the Lupron, especially when you become castrate resistant, which isn't your situation, you want to make sure that the Lupron is working because you're only castrate resistant if you are still below castrate level and your PSA is going up. Sometimes, the drugs can stop working.
Yeah. Well, and I wanted to monitor my D3 too because I'm taking supplements and, not getting outside because of the Casodex.
Yeah.
She said that's not necessary.
Well, you tell her, but you have to say, I want it done, please. Yeah. If you put it in writing and you say, I want it done, you tell her, I want it done because I'm taking D3 and I want to make sure I'm taking the right amount.
Okay.
And
thank you.
If you say it like that and you put it in writing to her in a message, it's in your chart. Then she's not going to say no.
Okay.
Some of this is just learning how to manage our docs.
Right.
Isn't that right?
Something else I asked her about was help with my hot flashes and cognitive problems.
Yes.
And I was suggesting the estrogen patch. I don't know what you guys think about that, but it seems like that theoretically is going to help with bone density, mental clarity, and hot flashes. She had never heard of that as a solution. She had to have to call somebody and ask them.
Well, there's a lot of controversy over the estrogen patch. I mean, I would say if it were me, before I went to an estrogen patch and the hot flashes were bothering me, I would start with acupuncture, which is available at Kaiser now.
Yeah, you mentioned that last time. It's on my list.
Right. Then if that didn't work, I would probably look at one of the drugs that might be out there, like Megastrol or Megace or Depo-Provera, but they do have some drawbacks. I think the estrogen patch probably has the most serious side effects because it is associated with cardiovascular issues.
Mm-hmm.
And I'm surprised she hasn't heard of it, given her background at UCSF, etc., because it's been around a long time.
Yeah, that was that whole session was of a lot of concern to me.
Yeah.
I brought up various studies. She'd never heard of them, wasn't interested because it, didn't relate directly to the standard of care, standard approach. And I looked at some of the profiles of the guys at UCSF, and the studies that she hadn't heard of, they wrote. So I'd much rather be sitting in one of those offices than trying to explain something that my oncologist ought to already know.
What saddens me is that if it was Dr. Steve that was talking to her, she would be paying attention and responding. And you shouldn't have to be a senior retired Kaiser doc to get the right sort of attention out of her.
Mm-hmm.
And I know how Shreya's responded to Steve, and he's been pretty happy with her. I mean, but he's led her like you've led her, but she's been responsive to what he said.
Right.
And
well, I talk about it's important to have a quarterback. I think for a short time I was entertaining this notion that I would go do all this research, I would come up with the best thing, and then I had to convince my oncologist of it.
Right.
The more I got into the research, the more I realized I was in over my head. It's so much going on. It's complicated stuff.
Exactly.
So I'd rather be getting led and coached and making contributions as I can along the way.
So it's confirmed that you have the new insurance starting January 1.
Yeah.
Just curious. I mean, if you don't want to discuss it on the phone, that's fine. Tell me later privately. But I am very curious about whether they dinged you on the premium.
Oh, yeah. I sent you an email on that. And I don't think so. If they did, it wasn't very much. Let me see if I can find that here.
So the issue, guys, this is important for everybody, is that when you switch, as you were able to do through December 7th, you can be underwritten. And there are underwriting criteria around prior conditions and pre-existing conditions. And the plans have two tiers. There are two rates on these plans, only two rates. There's a lower rate, which is what they advertise, but then there's a higher rate, which is about double. So, for example, in my area, the low rate was around $150 for a plan like, or $125 for a plan like Art just got. But if I had a pre-existing condition, they could move me up to significantly more. like I think around 280 to 300. And I just don't know enough about what that rate is going to be. And so Art was sort of a bit of a guinea pig. And that's why I'm concerned. I'm interested to hear what exactly he's paying. But go ahead, Art.
Okay, here it is. Let's see. 140 with United Health. That may include Plan D. They told me when I was talking with their on the phone agent who was taking my application to expect 127 a month plus Plan D at 27 a month. So that's 153 if you have those two together. They told me 140 when I asked a little later in the process, but I think I won't know absolutely for sure until I get the invoice in the mail.
But that's definitely a tier 1 rate. So they really didn't hit you. And then you have this issue with the pre-existing conditions where you can't see a doc for a pre-existing condition for 3 months, but they can adjust that.
Well,
do you know more?
Well, what they're saying is that they're talking about if pre-existing condition limitation applies to you, you know, then the 3-month thing. I'll see. It says any expenses incurred during the first 3 months after your effective date will not be considered if due to a pre-existing condition. However, they also say that pre-existing conditions limitation will not apply when you meet the open enrollment guaranteed issue requirements. And then there's a list of what those things are. One of them is if your premium goes up by more than 15%, you know, then you can skip the underwriting and you're guaranteed.
Okay. And you
it's on page 7, I think I sent you. You'll see it all there.
And oh, I see. So what you're saying, you're claiming is that your premium went up by more than 15% because the deductible went up.
Well, yeah, I'm not 100% sure that there may be a problem with this and there may not. Let's see, we're gonna get the right page. Come here.
All right. Well, I mean, we can talk about it later, but you raise a good point again that people should be aware of, that if you fall into that guaranteed coverage, which is things like you're moving from one place to another, or your Advantage plan gets dropped and you don't have any other choices, one of the conditions is if your premium went up by more than 15%.
Right, or if
on your Advantage
your benefits were restricted.
And that might be how you got in. We don't know.
Okay, here it is. I think I got it here now. Okay. There are 9 items, and if any one of those applies to you, then you beat the rap on pre-existing conditions and you get a guaranteed policy.
Right.
And I could read them to you, but the ones that...
Which one was appropriate for you?
Yeah. Well, let's see.
All right. Well, look, we've reached the witching hour, so we're going to. You and I can continue this offline, but at least the guys have a sense that there are situations where you, even if you're on an Advantage plan and you want to switch to a supplemental plan, you can do it, and just be aware of that, and you know what those conditions are exactly. We could maybe talk about another day.
Mm-hmm. Well, you have it in that certificate that I sent you, and you could share that with anybody that's interested if you want to.
Okay. All right. So, Peter, I'm sorry we didn't get to whatever you had, but it'll save till next time. So next our next session will be on the 26th, the day after Christmas, and we will hold that. It's on Boxing Day. For those of you who know what Boxing Day is, at 6 o'clock Eastern. Okay, so I won't speak to you again, at least as a group, before Christmas. So I wish you all a very happy holiday. Stay off. Don't eat too many of those desserts. Don't eat too much in general. And I'll talk to you next week. Okay? Goodbye. Oh, and thanks to everybody who's made a donation. We really appreciate it. Thank you. Thank you. Okay.
Thank you, Rick. Thank you all.
Good night, everybody.
Happy holidays.
Good night, everybody.